local chapter known as the National Association of Latino Healthcare Executives, or NALHE for short, for the Texas Gulf Coast region. I'd like to welcome all of you to the first of many collaborations with two amazing organizations, which includes the National Association of Health Service Executives, NASI, and NALHE, but of course I'm biased. And I'm joined today by Nasi Houston Chapter President Jonathan Leonard, and you will hear from him later in the program. But formally, I would like to thank him for supporting the vision to bring two similar and like-minded organizations, Nasi and NALHE, together. And I'd like to share how similar our two organizations are by comparing our mission statement. So if you give me a few minutes, this is Nasi's mission statement, which is the purpose of promoting the advancement of development of Black healthcare leaders and elevating the quality of healthcare services rendered to minority and underserved communities. Nasi's purpose is to ensure greater participation of minority groups in the health field. Its basic objective is to develop and maintain a strong, viable national body to more effectively have input in the national healthcare delivery system. The vision is NASI will be recognized globally as the premier professional membership society for Blacks in healthcare management. NASI strives to improve the health status, economic opportunities, and educational advancement of the communities we serve. NASI is committed to the association goals by providing professional programs, workshops, educational programs, job bank and mentoring, scholarship, student internship, community service projects, and policy impacting business contracts and opportunities. Now I'm going to read to you very briefly the National Association of Latino Healthcare Executives. Our mission is to promote health equity for Latino communities by increasing Latino and Latina representation within healthcare systems, and by supporting policy, legislation, and regulation that seeks to improve health and healthcare for diverse communities. Our vision is to be the professional association of choice that transforms the Latino and Latina experience in the national healthcare leadership space. So those are the two mission and vision statements, and aren't they very similar? We have an amazing agenda tonight, supported by well-recognized leaders on the panel to discuss very challenging but relevant questions that we are all facing. And I'll start off by saying, in a landmark study completed back in 2003 by the Institute of Medicine, and it was called Unequal Treatment. It concluded, and I'll quote this part of the study that I thought was very important to relay specifically. Racial and ethnic minorities tend to receive a lower quality of healthcare than non-minorities, even when access-related factors such as patients' insurance status and income are controlled. The sources of these disparities are complex and are rooted in historic and contemporary inequalities and involve many participants at several levels, including health systems, their administrative and bureaucratic processes, and utilization managers and healthcare professionals and patients. So when you think back, study 2003, I'm curious to hear what has changed over the past 17 years. And I hope our conversation tonight offers a hope that we acknowledge that health inequities are real, and more importantly, brainstorm ideas that influence positive change for our minority communities. But first, it's my honor to introduce our moderator, who I will hand the conference over to. So let me introduce Deborah Boone, and I'll read you her bio. Deborah Boone is a healthcare administrative fellow at the Baylor College of Medicine in Houston. She graduated from University of Texas Health Science Center, School of Public Health, and a master's in public health and healthcare management. As a graduate student, Deborah focused on population health, quality improvement, and innovation during her experience at JPS Health Network, Bannon Innovation Studio, and the Houston Health Department. Her personal experiences, both positive and negative, with the healthcare system served as a catalyst to change her career trajectory towards healthcare management. Before starting her career, Deborah worked in New York City for DWS Investments, formerly Dutch Bank. During her tenure at DWS, she focused on daily tactical elements of running a traditional asset management shop. while managing regulatory change projects and cost management initiatives. Additionally, she led innovation initiatives by launching new investment vehicles and facilitating an innovation challenge to bring more investment ideas and products to the platform. Wow, already, right? Deborah is an active member of NAHSE Houston chapter. She serves on the Health Policy Advocacy and Innovation Committee, where she supports professional development and enrichment activities. Additionally, Deborah is a NASI National Scholarship recipient and selected to participate in the mentorship program. Deborah is also a member of ACHE Southeast Texas chapter. In addition to serving as student board observer, Deborah earned an ACHE National and Chapter Scholarship. Outside of her professional pursuits, Deborah launched an inaugural Junior Leadership Board to help raise funds and recruit mentors for the Growing Scholars Program within Sponsors for Educational Opportunity, the SEO. In addition to serving as co-chair of JLB, she volunteered with the American Needs You as a Mentor Coach and facilitated an annual job shadowing program with the Fresh Air Fund. So on a personal note, if you're interested, she enjoys outdoor activities. She completed, I thought this was awesome, Deborah, completed the New York City Marathon, and she graduated from Hampton University, where she served as president of the Leadership Application Program and graduated magna cum laude. With that, I'll turn it over to the moderator, Deborah.
All right, thank you, Stephen, so much for that introduction. And everyone, and thank you all for joining us tonight. I'm excited to moderate tonight's panel, and the expert judges that we have tonight are Denise Larue, Dr. Judy Shaw-Rice, and Dr. Lavelle Jones. Introduce all three of our panelists, and then we will start the session. So first, Denise Larue. Denise Larue is a public health professional who serves as Director of Care Integration within Harris Health System's Population Health Platform. Denise has spent the last 12 years at Harris Health developing quality improvement initiatives, conducting program planning and management, and creating care coordination pathways for patient and community populations. Over the years, she has led teams of community health workers in various population health and access to care programs, aiming to improve outcomes in cancer screening, prenatal care, and diabetes management. Denise received an undergraduate degree in biology from Baylor University and her graduate degree from the UT Health School of Public Health. Next, we have Dr. Judy Shaw-Rice. Dr. Judy Shaw-Rice is a board-certified internal medicine physician and a medical director with United Healthcare, Community and State, based in Houston, Texas. Dr. Shaw-Rice has worked as an executive leader in administrative healthcare for over 10 years. Within the capacity as an executive management leader, Dr. Shaw-Rice's main focus is process improvement and program redesign. She has a particular interest in utilization management, population health, relationship building, and cultural competence. Before transitioning into healthcare leadership, Dr. Shaw-Rice was a clinician for 20 years, where she focused on management and reduction of cardiovascular risk factors in marginalized communities with an emphasis on women. She obtained her medical degree from the Medical University of South Carolina, completed her residency in internal medicine at Baylor College of Medicine, and earned a master's in medical management from Carnegie Mellon University. And our final panelist is Dr. Lavelle Jones. In 1980, Dr. Jones joined the University of Texas MD Anderson Cancer Center as an assistant professor in the Department of Gynecology and Biochemistry, where he served for years. As the first African American to be hired in basic behavioral sciences, he rose through the ranks to a tenured professor. During his tenure, he focused on the role of steroid hormones and reproductive cancers and health disparities in minority and medically underserved populations. Dr. Jones chaired the training session of the Strategic Fact-Finding Meeting on Minority Health and Training in Biomedical Sciences for the Office of the Associate Director for Research on Minority Health, which is now called the National Institute of Minority Health and Health Disparities at the National Institute of Health, the NIH. Dr. Jones earned a PhD in tumor biology and endocrinology from the University of California, Berkeley. He received his Bachelor of Science in Biological Sciences from Cal State Hayward. Thank you all so much for joining us tonight. We're really excited to have you on this panel, and I'm going to kick it off with our first question for you all. So the first question is, how does implicit bias affect patient care, and how can we help to move in the right direction to improve patient-physician interactions? Dr. Shaw, can you start us off? Dr. Shaw-Rice, excuse me.
so much. Can I be heard? Am I heard adequately? Can you all hear me?
Can you, if you can you turn your volume up just a little bit?
Okay. How about that? Is that better?
That's better. Do you have any more volume?
Is that better?
That's better. Thank you.
Okay, let's start on that. All right. So this is a great question. And, first of all, I just want to start off with making sure that we, all have a consistent understanding of what implicit bias is. So, without going into a lot of detail, this is something that not something that we can change from an introspective review, introspective evaluation of ourselves. This is something that has developed over our various years of experience and relationships from childhood, including the media and including various relationships that we have. So with that said, as a physician, a practitioner, a provider, when we are relating to other members of the environment, whether it be patients, whether it be other providers, how we look and see them, and how we relate to them as it relates to the issues that they may bring in the form of a patient, for example, affects substantially how we practice, what we recommend, what we suggest. We see this affecting many different areas of healthcare, particularly cardiovascular. There's rampant examples where Black females, people of African American, Latino cultures don't get the same level of care. And there's many different reasons, there are many different explanations, but suffice it to say, the level of care is disparate and is not the same. Oftentimes, individuals in these populations, their symptoms aren't taken seriously. Oftentimes, pain medication, sickle cell disease, other types of pain conditions that require pain medication. Oftentimes, these people from groups get treated with less pain because there's been this concept of understanding over the many years that for whatever reason, Black Americans, people of African American descent seem to have a higher pain tolerance. Not the case, but that is the belief. And so pain medications are less frequently prescribed. But there are many other examples that can similarly be given in many different groups. And so it's a substantial problem, whether it be outpatient, whether it be inpatient, whether it be surgical, whether it be in the ICU, intensive care unit. This is a substantial problem in situations like now where we have there's a significant disparate between the different populations. And this is something that unfortunately many physicians really are not aware of. In my growing up, when I went to medical school, we didn't talk about things like this. We didn't talk about cultural competence. It just wasn't something that was a part of our construct, part of our education. I understand that is something that is being included now, which is great. But unfortunately, there's a whole host of physicians who have no knowledge of that this even exists. And in fact, frankly, that it exists simply because it's not something we like to admit. I mean, we don't like to admit that we look at one patient differently from another patient, having the same conditions, the problems, medical issues, medications, really because of whatever their cultural background is. And I also want to just take a couple of seconds more just to make a distinction between race and culture. Because there are many people who may be people of, they have completely different cultural backgrounds. And, I hear people from Africa, people from people from, America. So there's just a lot of different variety that needs to be considered. And it goes without saying that substandard care is the outcome of not being able to appreciate the difference in cultural, racial variety. And it's really, I can't stress enough the importance of this kind of understanding, which sadly begins with the providers themselves. Um, Usually ones who like to point fingers inward, but it is something that the healthcare environment does need to pay close attention to.
Thank you for that insight. Denise, would you like to add anything?
Sure. Totally agree with everything that Dr. Shaw-Rice mentioned. And to add to that, Amy, from a very practical standpoint, what ends up happening is that, patients are painted with a broad brush. And there is less of a desire to kind of seek that individual understanding. What is the individual context within which that patient is living out their life. And one example, just that we tend to see a lot, chronic disease management is always at the forefront of the work that we're doing. We have a majority minority patient population that has a lot of underlying health conditions. And so chronic disease management is at the forefront of everything that we do. And a lot of our patients tend to be labeled as non-compliant. That we hear that all the time from providers. And it's a very dismissive label because it doesn't seek to understand the why behind this non-compliance. And so to answer the question of how do we help or move in the right direction to improve these, it's imbuing providers, number one, like Dr. Shaw-Rice mentioned, with that awareness, that implicit bias, and that kind of lack of understanding exists, number one, to begin with, and to begin to ask those questions. I call it the 3-year-old method. It's why? Why is this patient non-compliant? Let me try to understand, the cultural context, the socioeconomic context, the neighborhood context, what is happening in this patient's life, so that then I can give them an individualized treatment plan that takes those things into consideration, but isn't, kind of that broad brush treatment because I've made an assumption about this patient based on a couple of different factors.
Dr. Jones?
It's interesting hearing the perspectives from individuals. When you mentioned the 2003 report from the Institute of Medicine, I actually was the person that gave the opening address to that panel about the issue of discrimination and bias. So here it is 17 years later, and we're talking the same thing. That tells you something. It tells you that this issue is firmly ingrained in society. So this is just not a health issue. And if we focus it on as being just a health issue, we'll be here another 10 years later. This is a societal problem, as I said, and this past election gives you some indication of where we are. We are a divided nation that has opinions that are not conducive to addressing the issue of health inequities. And until we address this as a societal problem and not silo it in terms of different areas, we will be here again a decade from now trying to solve this issue. The other problem I think we face is that we have transformed healthcare from an infectious disease model to a chronic disease model. And what I mean by that is from community to specialties. When you look at it as a community or infectious disease model, I could hate your guts, but I'm going to make sure you get inoculated because I never know when I will come in contact with you. Approaching it from a chronic disease model, you can begin to accuse that person of everything. You don't eat the right food, you don't go to the right place, you don't live in the right area, and so on and so on. And so we need to really see down the road how we can begin to address this. And you mentioned in medical schools in terms of education, I will tell you that pre-chronic disease area, there was a lot more emphasis in terms of community than there is in medical schools today. If you look back and really look at the history of disparities, it really comes into place around the late 50s and 60s. There wasn't a major issue in terms of, if you look at infectious diseases, I used to joke, and I still joke and say that a public health doc will track you down to the furthest end of a reservation to make sure you're inoculated. Just because he doesn't know when you will come off that reservation and be a threat to his family or society in general. And so think about that as we approach this issue, because if we continue to silo it as a health problem, as a health issue, we won't solve the problem.
And Dr. Jones, you touched on health disparities, and that actually leads into the next question that I have for everyone. And what are some of the challenges that we continue to see, and what can healthcare professionals do to combat these health disparities?
Are you addressing that to me?
Excuse me? Sorry.
Are you addressing it to me initially?
You can start off, or anyone else on the panel if you'd like.
Well, I think that, as I said earlier, we need to look at this in a biopsychosocial or holistic manner. When I was at Anderson and I first started to approach addressing cancer and the cancer disparities, I realized very quickly, unless I began to address the issue with regards to other diseases, the impact on cancer disparity rate would be very minimal. And then I realized that unless I began to look at other impacting factors in terms of employment, in terms of education, in terms of a number of other issues, it would be a long road before I'd be able to do anything. The other thing that takes place is we don't celebrate the victories and we kind of discount them. How many of you know that somewhere around 2002, the disparities in smoking was eliminated? It's back again, but at that point, it is the only disparity that has been that was eliminated, and it was eliminated by taking a holistic approach in terms of addressing. But I think because it focused on a broad aspect of addressing health disparities, it got discounted by the silos because everyone wanted to claim victory and no one wanted to work together continuously to make sure that that occurred.
Thank you. And Denise or Dr. Shaw-Rice, do you have any thoughts about what are some challenges that we continue to see as far as health disparities go?
Yeah, I completely agree with Dr. Jones just said. I think that so often the focus is on this kind of discrete health outcome. Is the patient achieving or not achieving? And so the recommendations are often focused on the actions that will improve that outcome without any consideration for much else. And an individual provider might not be able to change that, but a healthcare system can, and frankly should. And I think that is really, the power of, where we are right now. This type of conversation that we're having today is, what will healthcare do to link arms across sectors to really think about, what are we doing together? We know that healthcare accounts for 20% of health outcomes, and there's everything else. And we can't do it alone, but how are we going to do it well and in tandem, not like you're saying, competing against each other, trying to claim the victory for oneself, but in concert.
I agree with that. I think one of the challenges, well, a few challenges, are the integration of the systems, or the attempt to integration of systems, and just the failure to be able to do that. So, we Dr. Jones mentioned silos. I mean, you can say silos in certain areas, and then you can just say just walls. So, I mean, they're just walls where they're just folks working alongside each other, parallel, but they just don't intersect. And sadly, they're working in the same, and but it's really not to anybody in this highly communicative world that we live in. Somehow we still don't know communicate. And so, I think everybody's doing their little piece. You have the doctors, the healthcare, insurance companies, the hospitals. Everybody's doing their piece, but we don't all have a system that will communicate. And it goes back to the issue of patient centricity. Again, another buzzword that we use. But unfortunately, much of what we do is not patient-centered. Maybe outcomes driven, as Denise said, but not patient-driven. I've always been of the belief that if you do the right thing by the patient, you're going to get the right outcome. But that's not always, what is followed. And I think just on another angle, sort of a corollary a little bit, is to understand that, there are different types of healthcare, and the understanding of health. So if we don't appreciate what health means to everybody, then we're always going to have a disconnect. Okay. So, as a doctor, you may want to, give them the super gun antibiotic and just spend 20 days in ICU and do the whole 9 yards. And really the patient may just want to go home and just be comfortable with grandkids and whatnot. And in different cultures, there's different concepts of health. And so, you have, I will can I just tell one small little story, a couple of minutes. I remember when I used to practice some time ago, and cardiovascular disease is my thing. And I just thought I was just the best thing since sliced bread. And, I would give my patients, advice and sit down, chat, and we talk. And I tell you, a certain patient of mine just wouldn't medications and just didn't want to do any of that. So she disappeared for a minute and then came back sometime later, chit chat. And so what's going on and what you doing? And she would say the medications are too expensive and then this and then all this. Can I tell you, she emptied a bag of vitamins and whatever else. And I asked her, how much did you spend on this? And I kid you not, she told me $500. I just wanted her to spend $20 on a medication. So, again, price is an issue, but a lot of times it has to do with what patients believe in, your ability to communicate with them. And I think we've lost that art a little bit in healthcare with being able to communicate with the patient in whatever space it is that they happen to be in.
I think one other thing, I'll tell you a short story that goes along with that. And I was involved at Anderson in terms of a clinical study, and we were asked to recruit minority patients to a study that had to do with cancer and diabetes. And the physicians that we were working with, I would have to say, were not very enthusiastic about having a diverse population within their study because they were being paid by the number of patients that finished the study and this whole issue of them not wanting to continue and so forth. And there was a patient that seemed like they weren't complying. The physician came in my office, sat down, told me that they needed to drop them, and they didn't want any more like these individuals on the study. And I said, what's the issue? And he says he's not complying. But he comes in and he tells us that he's taking the injections and he's doing all this stuff. And so I sent out one of my patient navigators to his home and found out he didn't have a refrigerator. And his insulin medication was sitting on the counter. And he was diligently injecting, but it was a case of him not refrigerating the insulin medication. And once we got him a refrigerator, the physician came back and said, wow, what did you do? He's so compliant. We addressed an issue with him. The other is with regards to how many of you are familiar with the Hope Long study that actually was the basis for early childhood education? They have now followed 140 plus individuals who were in that study that started in 1960. Looking at the healthcare issues, and briefly, the actual implementation was to educate 4- and 5-year-olds and get them ready to go to school. I think the last time they looked at it was 2000. The health of those 140 individuals was greater than the health of the individuals that they compared them to. The level of those individuals in terms of the percentages that had some interaction with the criminal justice system was less than 1%. The number of homeowners in that group was over 90%. And so what I'm saying to you is the issue in terms of addressing health and health inequities start way before that patient shows up in your clinic.
Thank you all. And you started talking about it a little bit, but I want to dig in a little further. What are the most effective interventions that have improved healthcare disparities? And Denise, if you could start us off.
Goodness. Maybe the researcher can start us off with that one. I think that, when you really think about it, it's going back to those upstream interventions that really are able to shape the decisions that people are able to make and the actions that people are able to take regarding their health. So, it really is going back to basics. It really is, as upstream as humanly possible, like Dr. Jones just referenced. It's pre-K, it's education, it's healthy economies, it's food access. The more upstream, the more community-based the intervention, the farther the reach, and the more stable the base, and the more resilient that community is able to be in the face of COVID, all of these things that come and are really highlighted, when we have situations like this. So that's a short answer, but I'm sure we can get some more specific examples. But the more upstream, the broader base you can get.
Dr. Shaw-Rice or Dr. Jones, would you guys like to add to that?
Yeah, I would say probably the system that has been the most effective in addressing health disparities has been the intervention of patient navigators or community navigators. That has been probably the most effective. I can tell you, at least when I was interacting with Memorial Hermann Southwest, in terms of cost versus benefit, that the intervention of patient navigators reduced the outgo in terms of the emergency room by about 90% while they had them effectively there. And what these individuals do is to become the interpreters for the healthcare system. And so to spend the time to know, just as I mentioned about the refrigerator and that sort of thing, to know what the needs are of that patient so they can maintain what their physician is prescribing for them to do, and also to help them get back into the system and navigate the system. The one thing that we found, and I've been working with the City Health Department, County Health Department with a small task force, strike force, in terms of addressing COVID. And what we have found is that unless you have these individuals who are connected with a system, when they come in to be tested and they leave, especially immigrants or low-income individuals, they get lost and off the grid. And because of the system that's in place in terms of trying to let them know that they're positive or negative, and sometimes they don't get notified for a week or 2 weeks, you have to find some way of actually getting those individuals to stay in, to quarantine themselves. And unless they have some system in place to make sure that happens, they're out and about. And we see what the impact of that has been and continues to be.
Yeah, I tend to agree with everything that's been said here. But I'm going to circle back a little bit to implicit bias and practitioners. So, we have a multi-pronged system, and we have providers, which those that provide healthcare. I know sometimes we use providers to mean vendors and all kinds of stuff, but we're talking about those that actually provide healthcare. And then we have healthcare systems, and then we have insurance systems, and we have ancillary, and we have all kinds of other folks. So, I've been around a little bit in many different aspects. And I've always said, when I practiced for 20 years, 20 some years, and then went to what we all call the dark side. And, when I tell physicians who I talk to sometimes, and I say, you know what, had I known what I know now, having gone to the dark side while I was practicing, I could have probably done a little bit better with some of the things. Had we had a better working relationship, we could have worked together in order to address the issues that the patient needs. So again, the things I think are central here is, and I sound like probably a recurring record, but is patient centricity and communication. I am a social determinants of health is something that is, I eat, sleep, and dream about social determinants of health and what we can do to circumvent. And there's so many different historical reasons why we are where we are, and all of that. And so there's a lot of parts of the onion that need to be peeled. However, that until we're able to really engage and empower the physicians and / providers and the patients, I'm not really sure that we're going to move the needle, because there'll be healthcare systems and then there'll be insurance companies. But without the physicians, the patients, really, they can't really exist. So, we have to get to a point where our physicians and our providers understand where they fit into the paradigm of the patient's health, and what can the systems do to assist the physicians / providers to help the patients help themselves. And I think it is important for us to know, again, when we're looking at biomedicine versus ethnomedicine. So when we're looking at these two different types of, and trying to meld these together, ethnomedicine being really more driven by culture, less by scientific, which is what biomedicine is driven more by scientific experience. So when we're doing that, I think we're much more able to move the needle and to assist the patient to help themselves. And so I think when we see it as that, as a provider, our job is to help the patient help themselves. Okay, help the patient maximize their health within whatever it is that health is. Okay. And I think if we have that as our central goal, then our outcomes will kind of follow. Okay. And I think a lot of times and when I say we, I mean the whole healthcare dynamic. Okay. Sometimes realize the practitioner is obviously very important, but we might forget that they don't really have the time to do the job that they need to do. And they may not necessarily have the tools, whether it be the cognitive tools from understanding the different types of healthcare, or whether it be the functional tools to assist the patient. So, with healthcare organizations working more collaboratively with physicians, working more really a collaborative environment with the patient at the center. And I think we need to get an understanding, we all need to get understanding from wherever it is that we sit as to what our barriers and our biases are. Okay. Because we talk a lot about, but we're not going to get very far. Dr. Jones alluded to the fact that it's really not a healthcare issue, but being that we're talking healthcare, everything that we've grown up with is affecting our ability to, as a patient, to interpret, and as a provider to provide the care. And I think it's very elemental. But I kind of think that's where we need to put our energy.
One of the things I see is, and you asked for solutions, and I truly believe in the patient navigator. And I'm not talking about the nurse navigator. I'm talking about the community navigator who is well versed and well educated. And I've seen them get by the biases and get the patient what they need. Because sometimes the physician doesn't know their bias. When this was presented to the 2003 Institute of Medicine group, I polled all of them at the beginning. And I dare say the majority of the physicians and members of the committee were very opposed to the actual committee because their sense was, I'm not biased. What do you mean I'm biased? I treat all of my patients the same and blah, 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 and so forth. But after the facts were presented to them, that was a unanimous report. There was no minority report because they could not confront facts. You're not going to be able to do that and have a group of physicians in a room and train them to get rid of their biases. They're going to bring it with them first. I have a bias. I tell people the story of me going home one evening, driving up, and the lights in the street not being on, and these 4 young African-American guys coming down the middle of the street with their pants going one direction. And I kind of sat in my car and looked at, and the news reports had been from muggings and everything else. And I sat there and I said to myself, what are you doing? Well, you can't be too safe. Well, this is a nice, well, you just can't be too safe. And finally, I convinced myself that I said, well, if I go and get the newspaper, which was at the end of the drive, which I wasn't thinking about, I said, I'm probably fast enough to run and get to my gate and lock it before they get to me, if they come after me. And when I went to reach over to get the newspapers, one of the kids said, hi, Dr. Jones. It was my next door neighbor. But you have that sense of bias. We all have it. It's ingrained in us. We live in this society. And to say that we don't have it and we never will have it, that's a false. But the key is knowing that you have it and acting on it.
Thank you all for those thoughtful answers. And we talked a lot about some of the challenges that we're facing, but the next question is there any research that tells us that we're moving in the right direction for improving health disparities, improving social determinants of health and health equity? And Dr. Jones, I'm going to pass it back to you for the research angle.
If you want reality, no. I'll be perfectly honest. I just saw, I wrote to Francis Collins several months ago. Francis Collins is the head of NIH. That was a RFA that came out on the need for educating communities with regards to the coronavirus vaccine. And I got the RFA simply because a friend of mine sent it to me because he looked at the list of people that it was being sent out to, and he didn't see anyone he recognized that had the real expertise to get the information out. I'll tell you, it's been funded. I'll tell you, it may do something, but in reality, I'm not that hopeful. I have to keep some optimism up, but we really don't have the people in the right place who are trained. We have people who think they're trained, who are doing the best that they can do. But really, when it comes down to it, it's going to take an integrated force from the community, from academia, from industry, sitting down at the same table, talking the same language. In reality, we don't have that across the nation. I think there are isolated places that do, that are trying to be effective, but right now, in terms of looking at the whole environment, it really doesn't exist. And that's being realistic. Yes. I could give you nice platitudes, but until we really sit down and be honest about it. One example, and I'll show you how it connects. The History Makers is celebrating its 20th anniversary. How many of you know the History Makers? Okay. History Makers started 20 years ago by a woman in Chicago who finished from Harvard in law school and then began to look at her family. And she was concerned that all she knew about was George Washington Carver and the Charles Drew, and you know the names, but didn't know of any other individuals who effectively altered the direction of the United States. And so she started by searching out and creating an archive of individuals that have made major, primarily African Americans, but who've made major impacts on society in terms of achievement. This past year, she went and investigated all the major libraries and archives in this nation. And what she found was less than 1% of 1% of the museums, archives in the United States had anything on African Americans in terms of impact. You might ask, what does that mean? Well, that has impact on what people's aspirations are. That has impact in terms of the workforce, in terms of who is in the workforce. And as I started, who you are and what you are and your human experiences have a tremendous impact on what you focus on and what you be successful in doing. Until we have a truly diverse workforce that's educated across the broad spectrum, we're going to be whistling in the wind. That's the way it is.
Thank you for the honest answer to the question. Denise or Dr. Shaw Rice, do you have anything to add about whether or not we're moving in the right direction?
I think there's a lot of conversation about the topic and, lots of talk, lots of chatter, lots of conversation, which is good. But, as Dr. Jones says, conversation has to move. There are lots of people who are doing studies. I mean, if you want to get large, like CDC or Health Organization, I mean, those folks are doing studies on a global level. And, CDC has many different studies within different regions. There are many different universities. I mean, there's, as Dr. Jones says, there's lots of lots of folks that are doing different studies. As I said, as or has been said as well, you know, social determinants of health is a big buzzword, and then that's been, you know, all kinds of studies are being done on that. You know, but you know, but you know that you know, and different organizations, different insurance company, different healthcare organizations. But again, everything's parallel. You know, everything's parallel, and what we need is a collaborative effort. I mean, you know, what we need is a collaborative effort, and of course, you have the large organizations, as I said, who have the capacity for that degree of collaboration. You know, but you need boots on the ground, and you need everybody talking the same language.
I would agree with that. I just to piggyback on Dr. Jones' comments, I have had to chuckle a couple of times when you see an RFA come out, and I'm not even talking about a big one, I'm talking a small one, and there, you know, it's a health disparities focus, and they're looking for outcomes 2 years down the road, and it's like, what can we hopefully expect to achieve in 2 years? You know, this is a giant issue. You know, I think from a very kind of like small localized perspective, you know, I think that there is exciting work that we're starting to see that, you know, doesn't solve the problem, but, you know, really speaks to the connection between social determinants of health and health outcomes. And I think that lends, you know, muscle behind the conversation that, you know, that this has to happen on a larger scale. You know, addressing food insecurity. Food insecurity is more of a, I'm going to call it a more low hanging fruit one, because you can work with food banks and whatnot to address food insecurity, for example, in a patient population. That's one of the things that we're doing at Harris Health. But are we addressing, you know, the totality of the health related social needs, you know, of patients? Absolutely not. You know, there's so much more to be done, but at least we're, you know, starting to connect those dots and really kind of fortify the conversation that might convince, you know, larger players or different sectors to join into the conversation, because that is exactly what we need.
One of the questions that I just saw, I wanted to get to it before the time runs out here. They asked about technology and its impact on health disparities. I'll tell you, it's had tremendous impact on health disparities in the wrong way. I was involved in looking at a study with regards to breast cancer disparities between Black and white women in Houston. And we looked at that issue over a 20 to 25 year period. And at one point, and I can't remember what I'm getting old, but I can't remember what the year was. It was somewhere around 70 something, maybe mid 70s, where the disparities between Blacks and whites in terms of breast cancer was almost non-existent in Houston. When we looked at around 2000, the mortality difference was 4-to-1. That wasn't a biological change. That wasn't a community change. That was an access change, and access to the best treatments that were possible at the time. And so in some instances, technology can be beneficial, truly, but in this case, it was not, because of how insurances played a role, people's employment played a role, whether they had disposable income to get the new and wing-dangle treatment that was there. All of that comes into play. And that's why I said we need to look at a broad aspect of it, because you may squeeze one end of the balloon and think you have it while it's exploding at the other end. And unless you look at it in terms of a broad sense, the problem is going to be there. So yes, technology can truly assist us, but unless you look at it in a broad sense, it can be detrimental in the same way.
One thing I just want to, Deborah, if I may, one thing I just want to just circle back, healthcare is local,
Right.
and what they say, health is determined by your zip code, not your genetic code. So, there's a lot to be said. I mean, again, different communities, whether you be African American, whether you be Caribbean, whether you be, Hispanic, Indian, Asia, whatever it is that your um, cultural origin is. I always believe that going local and empowering people within their community because there's always a leader in the community. Okay. And people look to that leader. And in some cultures, that type of leader's recommendations may not align with the MDs that they're going to. But that is a leader who they have in their community, whom they trust and who they are going to listen to, and more than you that went to medical school. I mean, what do you know? So, the point is that I think we have to keep remembering that healthcare is local. And we have these big organizations that do what they do, and we all do what we do. But that's where we need to go. And if we are able to mobilize our communities to do what they used to do back in the day, mobilize our communities with the head of the community, the ma'am or the madam, the whomever, whatever they call them, and get them to align with, and again, I don't want to use the word align, because you don't want them to align with what you want. We need to figure out what it is that they're seeing, what it is their opinion is, and what their healthcare situation is in their community, and what they need, and whatever it is that they feel is important to get their people in their community healthier, whatever that means. Okay. Whatever their definition of health is. So, I think we need to sort of take off the white coats and the suits, and loosen the ties, and get back to the level of the community to figure out, because social determinants of health, but that's where they all happen to be revealing themselves in the community. And I think we need to get back to that point where we go to the community, have conversations with the churches, with the little community rec centers, and whatever else it is that's there. Um, and work with that. The FQACs, I mean, those community organizations, those community clinics, they have the pulse of the community. They have the pulse of the people who are there. The rest of us who sit in our executive suites, not so much. So, I think that it's important that we circle back to recognize who's actually driving healthcare, and it's the patient that's driving healthcare. And I think we need to get back to the point where, from a solution standpoint, um, we empower these folks to make the changes that they need to make.
Yeah,
Sort
and
of
you
the
don't.
bottom up instead of the top down.
Yeah, and you don't wait until there's a crisis.
No. Well,
You don't wait until you need a grant, or or any along those lines. When I saw the news with regards to the African American and the Hispanic individuals going out to the communities with regards to the vaccine and getting people, they should have been there 6 months ago, a year ago. You just don't drop in and have somebody who looks like somebody else go in and say, hey, I've gotten a shot, you should get a shot too. It doesn't work that way. It never has, and it never will. But we still don't learn that. We still don't take that into account. And that's why we are where we are.
And Dr. Jones, that's a good segue into our next question, which is, this is a NAHSE and NALHE co-event. And what role does NAHSE and NALHE play in reducing these health disparities, improving health equity, and improving social determinants of health for Brown and Black people?
I think you're the connector between the community and the establishment. I'll put it that way. And hopefully you will be able to get this message across to them that until they embed themselves in the community in some way and listen to their voices before there's a crisis and working with them, we aren't going to solve the problem. We have to solve it together. And I think you guys are probably the best to do that in terms of being effective.
Thanks. And Denise and Dr. Shaw Rice, do you have anything to add?
Yeah, just to add, you know, I think this is such a fantastic forum for the sharing of ideas. You know, if we're thinking strictly from the healthcare system view, you know, how do we transform the way that we provide care? How do we integrate more upstream interventions? How do we learn to have conversations with sectors outside of our own? How do we change literally the way that we provide care for our patients, and thinking beyond just healthcare and going upstream?
Yeah, I 100% agree with everything that's been said. I mean, nothing much more to say, but you know, they say go to the Gamba, so you know, you kind of go to where the problem you perceive to be, you know, and that's how you solve the solution. That's how you get the solution. In fact, you know, you'll be surprised that people may even come with solutions from the communities that
Right.
you haven't even thought about. And, you know, you can't solve their problems. They can solve their problems.
Right.
And you have to ask. You have to ask.
Yeah,
Right.
yeah, you gotta ask it. Yeah.
And I have one more question for the panelists before we go to Q&A. I just like to remind all participants, please go ahead and start putting any questions that you have for our panelists in the chat section. And then when we open up the chat in a few minutes, we'll start addressing those questions with our panelists. So the last question that I have is, what is one action item that you recommend to our audience to help reduce health disparities for 2021?
Oh. Oh. That's a big one.
Who wants that one?
Dr. Jones, you can start with that one.
Yeah, I think that you begin to bring the communities that are in your area, where your healthcare focuses on, like Memorial Hermann Southwest, in terms of the neighborhoods that are within its area, and begin to establish relationships, long-term relationships, not relationships for this particular project or that particular effort, but visionary projects that look at how do we bring the resources of that community. And those communities have resources. It may not be monetary, but knowledge, long-term knowledge, in terms of how do we address the issues in the various communities that we reside in. As I said earlier, I believe your organizations can be that conduit in terms of making those connections way before there's a crisis. And maybe now you can go in and say, listen, there's a crisis going on. We should have been here a year ago. We should have been here 2 years ago, but we're here now. How do we make things better? And listen, don't talk, just listen. And they may be highly critical, but accept it and say, I know we should have and we could have, but you know, we're here now and we are listening. But more importantly, when you listen, act on the things you hear. Don't just sit there and listen and write it down and then go away. Because if you do that, they're not going to listen again. There's an example in Dallas, Mabel White, who was very influential, as you said, Dr. Shorewright. She knew the community back and forth. She basically had a high school education, but she was the realtor, she was the hairdresser, she knew everything that went on in that community. And I made a recommendation to an organization that wanted to do something within South Dallas. And I said, you have to go and talk to Mabel. Don't be surprised if Mabel slams the door in your face. And slams the door in your face several times. but you have to be persistent because you have to let her know that you're there for real. They did. It took them 18 months, but the result of them being persistent and dedicated has been beneficial to that community.
Yeah, I think just to follow up on that, I think we need to understand the value of culture and what cultural differences, how cultural differences affect the outcomes of care that we're all trying to measure from a metrics standpoint, and we need the knowledge, and we need to listen, as Dr. Jones says. We need to listen and realize we don't know, and realize that we don't know what we don't know what we don't know, and to go and listen with all hands on deck, with intent to act on whatever it is that we hear. But I think if I had one action items separate from what Dr. Jones said, it's for us as practitioners and clinicians and healthcare deliverers to appreciate the importance of cultural variation and the impact that it has on healthcare and healthcare delivery.
Yeah, and to add to that, maybe just saying it in a slightly different way, it is permitting yourself to understand context at the individual level, provider to patient, understanding the context within that patient lives. At the community level, understanding the barriers and the issues that that community is facing. From the healthcare delivery perspective, who else is out there that can impact this patient's health. And so it's looking a little bit outside of yourself, without these kind of horse blinders to this kind of very targeted outcome that we're trying to achieve, but really opening yourself to ask those very open-ended questions as to, what else is there to this? So it's asking the question and appreciating context.
And thank you all for all of those thoughtful responses. I'm now going to open the floor for the Q&A. So once again, if anyone else has any questions, please feel free to put it in the chat, and I will ask the panelists in the order in which the questions come in. So the first question for all of you is, what do you think is the disconnect between healthcare, communities, and minorities?
A lack of understanding, a lack of value, what the community brings. I've been in meetings where community members have been invited, and it's been more we can tell you than listening to them. And both individuals feel very frustrated in leaving, and nothing gets done. As I said, it's listening. I'll give you an example. Even I, being involved in this for a long time, kind of make faux pas. And I was working at the Chicano Family Center over in East End, and had this beautiful questionnaire that I had put together. I had it translated by professionals who I knew the language and everything else. And as I was presenting it, and I had been in that community for at least a while, so I developed some of the rapport. And as I was asking them for their feedback on the order the questions were being asked, these three elderly women who, seniors who I'd gotten to know, started laughing. And I said, is there something wrong? And they would say, oh, no, doctor, it's fine. I said, okay. And then I finally, after a while, and they're still laughing, I went into my, well, this is for the community. And if something's wrong, please let me know, blah, blah, blah. And they said, oh, no, doctor, it's fine. And I finally turned around and I said, okay, tell me what's going on. And they said, are are you sure you want us to answer questions 13, 14, and 15? I said, sure, yes, unless, there's something wrong with it. And they said, oh, doctor, it wants us to know how many hats we eat. Now, if I had not established a good rapport with them and have them tell me, I would have walked away with that questionnaire being asked, coming with the wrong idea, because in another area of the country, it referred to a condiment in terms of food. And I would say that's not eaten here. And so because the community knew that they could tell me, they could laugh and show expression and trusted that I would not challenge them with regards to their knowledge. To me, that's the key. That's establishing a rapport and respecting everyone for what they can bring to the table.
It's great.
Yeah, the only other thing I will just add to that is I think we have to also in the healthcare community and a little bit outside is to recognize the historical influence that past has on current habits. Okay, I know I don't have a whole lot of time, but specifically now where we're wanting people of brown and black communities to get COVID. Well, there's been lots of history, bad history with regards to African Americans and immunization injections and studies and whatnot in the past. And so that affects what happens now. I mean, that's just one example, but there are many other types with many other different cultural backgrounds. And I think it's important that we avail ourselves of the information to understand historically why X, Y, and Z is happening today, and why communities are in the position that they are today from a historical, economical, economic, whatever kind of reasons you want to, but we do need to not ignore that and realize that places are where they are, things are happening the way they're happening, people's responses are the way their responses because of some sort of historical significant episode or event.
Yes, and thank you for that. And the next question we have in the chat is, what, if anything, are health institutions doing to reach out and encourage young Black and Brown professionals to seek out careers in healthcare?
There are a number of things that they're doing, but one thing that I would suggest, not so much for the young professionals, but across the broad system, and that is, I know that at Anderson at one point in time, I don't know if they're still doing it, but we used to bring in physicians from different countries, from different areas, to see what the system is like, so that they would feel comfortable in terms of picking up the phone and calling someone there. At one time, which flew over everyone's head, I said, why don't you do that with the community physicians, especially physicians of color and those who treat underserved individuals, because they may not know what's available and what you can do and how to interact with that institution. I think that has a twofold impact. It has an impact on the physician and the people that they care for, but it also gives the feeling of a community, minority-friendly, underserved-friendly environment that a young person wouldn't mind being involved with. That would be my, and also interact with organizations that are involved with training young individuals, bringing them in, having internships, making sure that they feel welcome in that environment, but also to highlight those individuals who have served in those institutions. One of the things I've been working with the University of Texas system is try and get them to highlight their emeritus professors that are African American and Latino. The communities don't know who those are. I mean, if you do a survey, I dare say, if I can ask, well, I asked the audience here, how many of them know of a emeritus professor that's Latino at the University of Texas or any of the university systems within the state of Texas? Probably very few, if any. That's one of the problems too. You have to make people aware that they have been successful individuals. They probably can name the star basketball player that came out of UT or one of the other institutions, or the star football player. But what about the star sociologist or the star architect or the star scientist and that sort of thing?
Deborah, I think your question is really excellent, because I think that, you know, as healthcare systems, you know, this conversation of implicit bias doesn't just reside in the provider-patient relationship, but also, you know, at the organizational level. You know, like how does that play out in our hiring practices and whatnot? And I know that as an organization, that's something that Harris Health is looking at quite intently. And, you know, I would also be very, you know, interested in hearing, you know, just, you know, from an educational perspective, you know, what are the medical schools and other medical professions doing to attract more minority professionals entering those careers in the first place. So I think that there's traction. There's a long way to go, but there's traction there.
For the number that are in minorities in medical schools now is low. It's probably lower than it's been in decades.
Yeah.
And we have to look at why that's the case. Texas should not have a problem. You know, when I look at, you know, one of the things I asked several years ago was when I was outside the state many years ago, and even today, I know of more Texas expatriates, I should say, who are in other states who are Latino or Hispanic or African American. They're on faculties all over the nation. One of the questions is, why are they there and not? You know, I learned very, very early coming to Texas. Texans like Texas. They like to come home. The question is, why aren't they? You know, why aren't they? There are probably more Texans with MDs and PhDs outside the state of Texas on academic institutions than all the academic institutions, major institutions combined. Why is that? It's not a supply problem, not for Texas. You know, so that's a question that needs to be asked. Is the environment so negative that they fail to return?
And we have time for one more question from the chat, and I'm actually going to start this one off with Dr. Shaw Rice. The question is, what can we do as healthcare leaders to be true advocates and partners for our patients, especially minorities?
I think that's I think that's a great question, Elton. You know, one of the things I always like to say is lead by example. And you know, we as healthcare leaders, whether we be executive suites, whether we be clinicians or whatever the capacity is that we have, you know, I think we need to start listening more, talking less, and educating ourselves outside of the scientific arena, but educating ourselves as to the origin of the disparities, because we have to acknowledge these things exist. So I always make the distinction between you may not understand and you may not be able to understand, because if you haven't walked in somebody's shoes, you may never understand, but you can at least hear, listen, and acknowledge and accept what it is they're going through, or whatever it is that is affecting their healthcare needs, as that's what we're discussing here from a healthcare standpoint. And I think as a clinician, you need to spend a little bit more time, as healthcare leaders, we need to spend a little bit more time listening to whomever. Sometimes it's to the patient, sometimes it's to the family, sometimes it's to the daughter, the sister, the whomever. Sometimes it's the neighbor, the leader in the community, the church, the minister, whomever. But we need to spend more time listening and melding all of this information to come up with a package deal as to how we're going to address the needs of the of the particular member, of the particular patient. And then, as I said it before, lead by example. As advocates of care, as advocates of health, we don't have all the answers wherever, quote, we sit, but we definitely know who to bring into the fold to help us to get to the answers. And I think from a networking standpoint, we need to know who we are and know who they are and know who everybody else is, so that we can, at a whim, pull these people in. One of the things that I find, unfortunately, whether in practicing or a non-clinical environment, we spend a whole lot of time on administrative burden. And we spend a whole lot of time trying to figure it out and less time doing it. And I think if we had a better environment, working environment amongst us all, wherever we are, and we can pull together, and whether you be on the front line, whether you be sitting in the C-suite, whether you be on the street, wherever it is that you happen to be, and pull our resources together in order to satisfy the needs of the patient, member, or wherever we sit, from whatever direction we sit. And I think from a physician who practiced for many years, if I had to do it all again, I would definitely look at things from a little bit different perspective. I was pretty knowledgeable back then, but I would definitely look at things from the perspective of pulling in as many resources as we can to do that.
Thank you. And that is a great note for us to end the panel session. Once again, on behalf of NAHSE, we'd like to thank you all so much for your time and sharing all your wisdom and insight tonight with our participants this evening. Thank you so much for your time. And with that, I will turn it over to Jonathan, the president of the NAHSE Houston chapter.
Wow, thank you all. What a wonderful panel. Thank you, Deborah, for moderating. My mind is blown right now because of all the great information that we received tonight. So thank you all. Again, thank you, Deborah, for moderating. You did a great job. Thank you to our panelists, Denise, who represented Harris Health, Dr. Shaw Rice, representing United Healthcare Community Plan of Texas, our Medicaid line of business, and Dr. Jones. And then also I want to thank Deborah Ponce and Cecily Collins as well for helping put this event together. And last but not least, I certainly want to thank Stephen and the NALHE family for their agreement to participate in this program. And I'm looking forward to a long collaboration with you all, because as we heard in the panel, it starts with collaboration, and we, our respective organizations, have a really big responsibility in helping reduce health disparities, improving social determinants of health. So we have a lot of work to do. And just as a quick recap, we have a lot of work to do. The data says that, and we know that, but we have a lot of work to do. Some of the things that I heard, we know that we have to recognize our biases. We know that health inequities don't just start when the patient is in the office, but they start way before that. So we have an opportunity and obligation to address those things. I also want to key on something that Dr. Shaw Rice mentioned about the historical mistrust of the medical community, specifically by Brown and Black people. There's a great book that I read by Harriet Washington. It's called Medical Apartheid. If you get a chance to, please read that. It's a really good read, and it talks about some of those things that have happened in America to minorities and why there's that historical mistrust of the medical community. Last but not least, we certainly want to be able to celebrate victories, although they haven't happened as often as we'd like. We want to celebrate the victories as they come, because again, if we don't celebrate it, nobody else will. So, and then the last thing I want to say as far as an event recap, NAHSE and NALHE have a really big obligation to celebrate our individuals and our members that are doing really good things in the community. So we haven't historically done a good job at that, and I want to challenge us as two organizations to do that moving forward in 2021. I also want to challenge you all, those who have joined the call tonight, to join our organizations. We need your help. I'm one person, Stephen's one person, but we really need everyone's help to make our healthcare community a much better place. I will send the respective links to our organizations in the chat. You should have it now. Become part of the organizations. I'm a member of both, I'm happy to say. I've been a member of NASI a little bit longer, but certainly I'm excited to, again, partner with NALHE because our missions and visions are pretty much the same, and we serve, again, minority communities. I also want to advocate for some of the upcoming events we have, and certainly please follow both of our organizations on LinkedIn. On January 21st, Nasi Houston is having an event which I think after this year of 2020, certainly applicable, but we'll be meeting with Dr. Trinette K. Pierre, and she'll be talking about combating in the midst of healthcare and social crises, again, which it seems like it's been all of 2020. And then on March 6th, Nasi Houston will also have its annual Women's Conference, which Deborah is actually one of the co-chairs for planning that event, and we'd love to see you out there. And again, please follow both of our organizations on LinkedIn. With that, I will say happy holidays to everyone. I hope you have a great new year.
Same to you.
Thank you so
Thank you
much.
all.
Good evening.
Thank you. Great presentation. Thank
Okay.
you all.
Bye-bye.